shut it off until you start.
this one's on right here.
That's fine. Good afternoon. Ground rounds today will be presented by Dr. Sarah Oberstreet. We're very proud she's one of the GI fellows, the only woman in the GI fellowship, and she will be the only GI gastroenterologist female in the city of Tulsa. There's only a few women in the field, so we're very proud that she is a part of our program. She graduated from Northeastern, did her residency in internal medicine here at OSU, went out in private practice, was with St. Francis, was a hospitalist, and had a private practice before she was called back to duty into fellowship. She is getting close to ending her first year. She's almost half year, but her first year in GI. She was only a few months into her program when we asked her to make a presentation to the Arkansas-Oklahoma Endoscopic Society, and that's a group of gastroenterologists in the two-state area. It's pretty unusual to ask a first-year fellow to do a presentation. Not only did she do it well, did it with style, and we were very impressed, and she's speaking on this same subject that is very difficult. End-stage liver disease we don't have a lot to offer. And so she's going to talk about that, particularly fatty liver, okay, and issues about that. So I'm going to talk about that. And so Sarah's going to talk about end-stage liver disease and new epidemic.
Thank you, Dr.
Sarah,
James.
yeah.
All right. My lecture today is a little bit different than what I did in Dallas. I'm focusing more on treatment and non-alcoholic fatty liver disease and other things. One of the things I have to kind of keep in touch a little bit with Dr. James with gastro. I know you guys get a lot of candy from him, and usually when you see him, you get something. So what I did was I have one question right off the bat for you guys, and whoever gets it right gets a Starbucks gift card on coffee on me, $5, okay? So it's going to go through the medical students first because they should know my question. And I'm going to ask my medical student actually because I have been talking to her all week about my lecture, and I know she's going to know the answer to the question I have for her. So right now, Gloria, is there an FDA-approved medication for NASH? Very good. There is not. There's a lot of studies on different things going on right now in fatty liver disease, but there's no FDA-approved medication or treatment options for people with NASH. So we'll start off first. Just a little intro. So I'm going to say NAFLD a lot because I'm not going to keep saying this long, non-alcoholic fatty liver disease, every time. So it's one of the most common causes of liver disease worldwide with a prevalence of 15 to 30% in the Western population. It increases to 58% for overweight and up to 98% non-diabetic obese individuals. It's a major disease plaguing the nation and the world. Definitions, a lot of people don't sort of understand this when I talk to students and different people. In non-alcoholic fatty liver disease, there's two subtypes. There's fatty liver and then there's NASH. And then fatty liver so it's subdivided. And so you have, just with simple steatosis, you just have fat without evidence of hepatocellular injury. And that's categorized as primary or secondary causes. What causes that? And then NASH, of course, is hepatic steatosis associated with hepatic inflammation, hepatocyte injury, and actually ballooning on biopsy with or without fibrosis. So here's kind of a table of the breakdown. When you think of NAFLD, you need to think what caused it. Was it primary causes, what we always think, obesity, glucose intolerance, insulin resistance, hypertriglyceridemia, kind of like a metabolic syndrome kind of picture? Or is it secondary cause like TPN, nutritional, or like did they have a gastric bypass and they lost weight too fast, things like that. Is it autoimmune? Is it genetic? You just have to take all these things into perspective when you're diagnosing and treating these patients. So for some reason, my top line did not show up. So the pathogenesis of NAFLD, you have to think about it. It's not totally understood what causes it, what precipitates it, what happened to those people that all of a sudden now they have fatty liver. So it's not fully understood. A lot of it, as we know, part of it is due to insulin resistance, oxidative injury. It can be due to iron, there's all kinds of deficiencies also too, but the biggest one that I want to talk about that you really need to know that every time I read journals now on fatty liver, this particular pathogenesis comes up, and it's intestinal bacteria. Oh, that's why. It's on, funny. Okay, so this is just for you guys to kind of see a big picture of it. You know, bacterial microflora, you don't have a lot in your mouth, and as you travel down through your intestinal system, you really start picking up millions into the terminal ileum and as you go into the cecum. So most of the time for bacterial microflora, it's gram-negative bacteria that is proficient in translocation. Your E. coli, Klebsiella pneumonia, Enterococci, and Streptococci. These are a lot of the infections you see in chronic liver disease patients. So one of the things that I feel like you guys should know a little bit about is the gut-liver axis. And so the liver receives 70% of its blood flow from the portal vein. This organ is mostly exposed to the gut-derived toxic factors from our gut. And the variations in our intestinal bacteria result in a variety of actions by the liver to counter-effect this. So when you have a small intestinal bacterial overgrowth, with that gram-negative bacteria, what you're going to end up having is damage into the intestinal barrier. You're going to increase your permeability, and you're going to have endotoxin translocation from this. You're going to induce transcriptional activation of pro-inflammatory genes and cytokines from your liver that's going to make an inflammatory response, okay? This increase in bacterial LPS is associated with chronic liver disease. You'll see a lot of sensitivity to the liver to LPS from the bacteria breakdown and endotoxins. So your liver is going to counter-effect this kind of, attack from the bacteria onto the liver. It's going to stimulate the immune cells of both innate and adaptive immune system. You're going to have activation of Kupffer cells via bacterial products that are triggered release of tumor necrosis factor alpha, which causes a lot of inflammation response. LPS itself is a hepatotoxin, and it stimulates an acute inflammatory response in the liver. So this is kind of what we talk about. You're going to have, I got a pointer. Okay, you're going to have small bacterial overgrowth of that bad bacteria. And what causes that? Is it your environment, what you eat? Is it genetic? There's lots of things that cause this overgrowth. And so you kind of have, is it what we put in our mouth? Is it the hormones in our food every day? There's lots of speculation about what causes all these things. And when you get the overgrowth of the bad bacteria, you're going to have damage to your gut barrier. Your desmosomes, your tight junctions that we learned about in medical school, those start breaking down, and you're going to get translocation, okay? So kind of what I said, it leads to alterations in the tight junctions. You get increase in intestinal permeability, and you get bacterial translocation of bacterial products into the liver. You get some PAMPs, which are pathogen-associated molecular patterns, which travel over caught in the bacteria byproducts. The most studied one is LPS of the bacteria. And then you also have pathogen recognition receptors, which are located in the liver, and you have your toll-like receptors and your nod-like receptors. And these are on your hepatocytes, your hepatic stellate cells. The most prevalent ones really are TLR2, 4, and 9. So you have toll-like receptors on your Kupffer cells, hepatocytes, and hepatic stellate cells. TLR4 is specific for LPS, which stimulates pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-6, interleukin-8, and interleukin-12, as we know, are inflammatory response. And this causes an inflammatory state in your liver. So here's kind of the same kind of picture a little bit. Here's your PAMPs and DAMPs. Okay, what they found out in some of the recent studies of kind of going through the gut flora biome is that there's been a couple of studies that show that there's fewer Bacteroides and an increase in Firmicutes in obese patients or insulin-resistant patients. Now, there's two studies that show this difference. One study didn't show it, but they didn't have as a big a population as the ones that were positive for this. High-fat diets is what they found have an increase in LPS levels in general. This increase in LPS levels lead to obesity, diabetes, and hepatic insulin resistance. LPS itself increases global liver weight and triglyceride content in the liver parenchyma, and I'll show you here in a second. Inflammatory mediators induce a state of insulin resistance. Why? Because these inflammatory mediators cause receptors of insulin to dephosphorylate, and they are not active. So your gut microbiome and hepatic fat, I'll kind of talk about that. Liver steatosis is a hepatic manifestation of metabolic syndrome. What happens is that in your gut flora, really non-digestible and non-absorbable polysaccharides get broken down into monosaccharides and short-chain fatty acids. These are hepatic gluconeogenesis and acetate are precursors of lipogenesis in liver and adipocytes. Also, the gut flora inhibits AMPK action. What does AMPK do? It decreases fatty acid synthesis and decreases glycogen storage. But your gut flora inhibits this. So it's going to increase fatty acid synthesis, and you're going to have increasing glycogen storage in your insulin resistance in NAFLD patients. Also, monosaccharides inhibit carbohydrate response element binding protein, which causes an increase in transcription of several proteins for hepatic lipogenesis. What does this all mean? This means is that you're getting more and more fat storage in your liver. Okay, your fatty acids then activate J&K and some IKB kinases, which promote lipogenesis, inflammation, and hepatic insulin resistance within your liver. There's also fasting-induced adipose factor in your liver, and gut flora decreases expression of this. And what does this do? This increases lipoprotein lipase and enhances release of fatty acid. Just another enzyme that's causing more fat accumulation in your liver. So hepatic fat itself. So fat deposition in the hepatocytes induces expression of fast and fast ligands. This induces apoptosis and lipotoxicity. It increases oxidative stress in the liver itself because now you're stimulating your hepatocytes and they're breaking down all this oxidative stress, and then you have cell death, and so this all starts stimulating more inflammation within the liver. This also increases liver sensitivity to LPS because you have upregulation of toll-like receptors 2, 4, and 6, which are specific in hepatocytes and hepatic stellate cells, which cause more inflammation. So here's kind of the big picture. I know it was a lot to digest, but what happens in the scheme of things with gut flora when you have an increase in gram-negative and small bowel overgrowth production of gut flora, you're going to start having more deposition of fat in your liver. Also, what happens is this GPCR also stimulates these couple protein receptors, also stimulates something called PYY, which is neuroendocrine. This hormone itself actually increases your caloric extraction from your gut. So you're taking in more fat. So this is kind of a vicious circle. Your bacteria overgrows in your gut. You get increased inflammation in the liver. You get more fat deposition in the liver. You get inhibition of certain enzymes that cause even more fat to be accumulated in the liver. And then you also get increased extraction of caloric energy from your gut. Okay? And so this all leads to non-alcoholic fatty liver disease. And I just think this is kind of important because I keep reading about this in all of the journals that are out right now that talk about treatment and pathogenesis of non-alcoholic fatty liver disease. And so as you continue your education, you'll probably hear a lot more about this and even more studies coming about. Okay, now back on track. So some of the comorbidities associated with non-alcoholic fatty disease, as we know, is metabolic syndrome. Obstructive sleep apnea actually does too. Diabetes, older age, obesity, and cardiovascular disease. I put this in here for all the cardiology guys. A positive ultrasound for non-alcoholic fatty liver disease is one of the strongest predictors for a positive angiogram. We read that in our Mayo book, and I thought that was very important. I'd never heard that before. And so if they have fatty liver, you see it on their CT ultrasound, just by happen chance they get an angiogram. Now you know it's probably going to be positive. Factors associated with disease progression of non-alcoholic fatty liver disease, your elevated liver enzymes greater than 2 times upper limit of normal, or presence of ballooning degeneration plus Mallory-Highland or fibrosis on biopsy when you do a liver biopsy, your BMI greater than 28, and how you store your fat is very important. You have high visceral adipose index, waist circumference, the BMI, triglyceride, and HDL levels all can contribute to progression. So diagnosis of non-alcoholic fatty liver disease. How do you diagnose this? Is it just by ultrasound? Is it just by metabolic syndrome? There's a couple of things you need to know. You need to have a high index of suspicion when you see your patients. Are they overweight? Do they have metabolic syndrome? And so there's not really any guidelines to say when you should screen these patients. And so you have to be smart about it. You have to be educated and know when you should start screening patients. Most patients are asymptomatic. They won't complain. Sometimes they have fatigue or just really they don't complain about a little abdominal pain maybe. But what happens most of the time, you get them in your office and you have an ultrasound that shows fatty liver, or all of a sudden you have some increased liver enzymes. What do you do next? That's kind of what I want to talk to you guys about, because you're going to see this in your office and you're going to be asked about this. So diagnosis of non-alcoholic fatty liver disease requires all of the following. You must demonstrate hepatic steatosis by imaging or biopsy, exclusion of significant alcohol consumption, and exclusion of other causes of hepatic steatosis, kind of like what I discussed, primary or secondary. So how much is too much alcohol? We see this all the time, and we even in our book club, we're like, looking it up, how many grams a day did that? So what I did was I looked it up, kind of ballparked it, and so women, if you drink more than 10 drinks a week, is a lot. That's significant alcohol consumption. Men is 15, and when I mean drinks, I mean liquor. Beer is 2, and so liquor is 1, depending, because of course it depends, one shot versus a 20-ounce, drink versus other. And if you really talk to patients, they're going to say they drink a cup of wine a night, or I have a couple beers a night. You start calculating that up, and that's actually a lot compared, to what a lot of doctors feel can be detrimental to your liver. So really ask that and realize that they're probably lying to whatever number they tell you anyway. So it's probably a lot more than they say. So some of the laboratory studies that you see obviously will be an increase in liver enzymes. Now your AST-ALT ratio should be less than 1. The higher the ratio, the worse of fibrosis, okay? They correlate. You have an increased ALK phos, you have an increased GGT, and you're going to have insulin resistance like metabolic syndrome. And you're going to have dyslipidemia, so increased triglycerides, LDLs, those things, and low HDLs usually. So rule out lab work. We talk about this a lot. We do a lot of lab work when we get consulted on patients with just increased liver enzymes, or they just have fatty liver. You have to rule out. So you're going to, of course, rule out your hepatitis panel, your chronic causes, your autoimmune causes, your genetic causes. You need to rule out primary or secondary. That's a big thing. And I know a lot of you guys didn't have Dr. Hitzman, but every time there was a mishap, it was in lab or we couldn't explain it, it was always meds. And that's a good thing to always remember, because half the time, a lot of medications do cause increased liver enzymes. So you've got to make sure and rule that out. Initial diagnosis of non-alcoholic fatty liver disease, of course, everyone's going to get a right upper quadrant ultrasound. We want to see what your liver looks like. Now, there's something that I thought was really interesting called Fatty Liver Index Algorithm. It's based on 4 markers: your BMI, your waist circumference, triglyceride, and GGT. It has an accuracy of 84% in detecting fatty liver. It's out of 100, so if you get less than 30, you can rule out fatty liver disease. If you get greater than 60, you rule in hepatic steatosis. And there's a big formula for it. You can get it on your Hippocrates. So here's some of the clinical features I highlighted from my book already. But this is kind of what I have talked about already, just to kind of recap. So you look for clinical features. Lots of times they're asymptomatic. You're going to see increased liver enzymes. You're going to see increased GGT, ALK phos. You want to get an AST-ALT ratio. And then you want to do imaging. And you've got to make sure you exclude heavy alcohol drinking. They also talk about binge drinking. They might not drink during the week, but if you drink a 30-pack on the weekend, guess what? You're going to have, that's really significant. Some of the non-invasive testing that you can do with non-alcoholic fatty liver disease, so you do not have to do a biopsy, is something called the NAFLD fibrosis score. It can exclude advanced fibrosis. It has 6 parameters, as you can see: age, hyperglycemia, BMI, a platelet count, albumin, and an AST-ALT ratio. Advanced fibrosis can be excluded with a negative 1.5 score. Okay? And in diagnostic, with a high cutoff of greater than positive 0.676. This test accuracy is used on most of the journals that you read about non-alcoholic fatty liver disease and treatment and how they scored it. This is the one that I've seen used the most. This is the most accurate, again, in the 80 percentile. Now, they also have something called the fibrometer that confirms advanced fibrosis. They don't use this one as much. It's just mentioned. So I wanted you to let you know that it's mentioned, but a lot of the studies actually don't use this one. They like the NAFLD fibrosis score better. You'll hear a lot of talk about in all the recent studies coming up, too. The FibroScan, which is something that Dr. Hunt liked a lot, that I learned from him, actually, to begin with, it measures liver stiffness. It was first introduced for hepatitis C and to see how stiff the liver was. Now, what it does is it sends out a pulse to the skin like an ultrasound, and it circulates to the liver, and you get a velocity of the wave that correlates to the liver stiffness. And they actually have measurements for that and staging. So when you do a fiber scan, you automatically know, fibrosis-wise, what the stage of that is just by this wave. And I know CTCA is actually looking into getting it, and so I hope they get it soon so we can have more experience with it. So here's the clinical approach. This is what you guys need to do when you see these patients in your office, even in the hospital. You need to kind of make sure and think about this in your head when you're coming up with a differential diagnosis and what to do. So first, we always want to consider screening of our patients if you're in the clinic. Who's at greatest risk for fatty liver disease? Obviously, your obese patients. Where you store your fat is very significant to you. If you have a lot of girth, that's going to be a risk factor. If you're metabolic syndrome, diabetic, and like I said before, there's no guidelines on screening, but it has to be your clinical suspicion and you knowing your patient well enough and doing good labs to kind of see this in your workup. The other thing is always to rule out. You're going to rule out autoimmune, like we talked about before, genetic causes, medications, those things, and you're going to get an ultrasound. You can do an ultrasound, or like we talked about, the fatty liver index too, to see if they have steatosis, rule in or rule out. After that point, now you need to stage it. Now you have diagnosed that they have fatty liver. What do you do next? What you're going to do is some staging options. So there's invasive staging of non-alcoholic fatty liver disease, so liver biopsy is the gold standard for diagnosis. But when do you do a biopsy? Now, if you look at the guidelines, they'll say when you know that they have increased risk of steatohepatitis, and they have an advanced fibrosis scoring. If they're metabolic syndrome, in patients that are suspected of non-alcoholic fatty liver disease. So if you have high probability for advanced fibrosis on your non-invasive testing, you can get a biopsy. If you're uncertain or unclear what the etiology is of the fatty liver, you want to get a biopsy. This one is one that we see a lot when you have increased serum ferritin 1.5 times higher than the upper limit normal. Is it hemochromatosis? How do we make this, delineation? So biopsy can be used for these things also. So histological findings in liver biopsy, what you're going to see is for simple steatosis, they break it down. If you have greater than 5% of steatotic hepatocytes in the liver tissue section, it's going to be mild. You're going to have moderate and then severe. You'll have macrovesicular steatosis, or you might have a mixed micro and macro. On NASH, you'll see steatosis, hepatocyte ballooning, all peptide bodies, lobular inflammation, and chronic portal inflammation. You also see this chicken wire, which is kind of cool. I've pulled up a lot of slides on that, and it's just the pattern of the collagen deposition within the liver. You also see Mallory-Denk bodies and lobular lipogranulomas. So here's pretty pictures. Here's just simple steatosis. Here's ballooning. And what we mean by ballooning, like I'm going to pick this one out. This is a hepatocyte, and you start seeing these balloonings of fat laden that's coming into these hepatocytes, okay? That's what they mean. You can see them all through here. Here's starting beginning. So you'll see those in your hepatocytes. Mallory-Denk, they actually call this a roped appearance. So that's what they look under like in the microscope. And then here's chicken wire. They do it blue. So if you've ever lived on a farm, you know what chicken wire looks like. So it's kind of like all over the place. And so that's how the collagen gets laid down within your liver. Okay, so the NAS score. When you hear the NAS score, they're talking about what they're seeing on the liver biopsy. So it's an individual scores for steatosis, lobular inflammation, hepatocellular ballooning, and fibrosis. So if you have a NAS 1 or 2, it's just non-alcoholic fatty liver. If you have 3 or 4, it's borderline NASH. Anything greater than 5 is NASH. And you'll hear this scoring system used a lot in studies when they're trying to see, when they like using vitamin E or when they're using URSA. This is the biopsy scoring system that they use to see if there was improvement with those certain medications. So here's just a big broad picture of it. So summary of clinical approach. First, we want to identify our patients with non-alcoholic fatty liver disease by metabolic risk factors, profiling, LFTs, or imaging. Positive steatosis and other causes have been ruled out, meaning how much alcohol, of course, and other genetic and autoimmune causes. Then we want to risk stratify them by non-invasive staging and say if they're high risk, moderate risk, then if they are moderate or high risk, then we are going to biopsy them to see if they have fibrosis or NASH. And And what's the management? So now you have this non-alcoholic fatty liver disease patient. Let's say they have NASH. What are you going to do now? What do you tell these patients? What can they do to improve this process? The biggest thing is right here. Lifestyle modification. This is your proven, tried and true, okay? This is what you're going to hear from most doctors to say. So, what you guys need to know is that when you tell people they need to lose weight, they're going to say, okay. I mean, they think it's a significant amount, but if you really look at the studies that they've done, if you lose just 3 to 5% of your weight, you're going to show improvement. And your liver enzymes will improve, your histology and pathology will start to improve. 7 to 10% will reduce steatosis and hepatocellular injury. And this is big. I mean, so you really need to push your patients that a little bit of weight at a time. It doesn't need to be, you need to drop 100 pounds. This is huge. And increased physical activity itself reduces hepatic steatosis independent from weight loss. Just being physically active is big. And so that's what you need to stress to your patients. You know, don't be like, okay, you need to lose weight and be done with it. You really need to talk to them about a percentage. 0.5 to 1 kilogram per week is what we like to see. But don't make it the elephant in the room. You need to give them a really big goal. I used to give my patients, when I was at St. Francis, I had my own diet plan that I would give them so that they could lose weight and lose it and be proud of themselves and know that it was an obtainable goal. Okay, that's the biggest thing. Okay, some of the medical management that all of you guys have always heard about, I'm sure, is vitamin E. Some of the liver guidelines will say 800 international units, but when you do read the research now, in some of the hepatology guidelines, what they say now is actually 400 international units, but non-diabetic NASH. Okay, they cannot be diabetic. And one of the things that they found is that vitamin E in general causes increased mortality, and they're still doing workup on this, and so it's not recommended as single treatment, but 400 units you can use for a non-diabetic NASH patient. Metformin, it's not recommended, but it does cause weight loss, and you can control your sugars better, which is also good for your NASH patient. Lactose, we've all heard this too, but of course it's risk versus benefit. It can treat NASH, but it is long term. Once you stop it, what they find out is that you just revert back. So you have to continue lactose long term, and as we know, it has adverse events of congestive heart failure, weight gain, which is not good, also right, and then edema. Urso shows no histological benefit. And if you look at some of the new treatment journals, they'll talk about this and how there needs to be more studies. But as of right now, with 3 of the studies they've done on it, in the bigger population, it has not showed any benefit. Omega-3 fatty acids did show some improvement in steatosis, but studies are still ongoing, so they don't recommend it. But if you have a patient with dyslipidemia, why not? That would be something that you should start. Statin therapy, or atorvastatin, improved liver enzymes. But it's not recommended for treatment alone. But again, if they have dyslipidemia, then you should start it. Methoxyphylline showed benefit, but recent studies that I pulled on this specific medication failed to support it. So they did bigger population studies, and they didn't improve as much as they thought. And the biggest thing was also that we've actually read a lot too, is that it causes a lot of side effects, nausea, abdominal pain, and people weren't as good as being compliant with it because it was causing a lot of problems. New therapies. What's new? What's on the horizon? That's really funny. I think Gavin put this in here. So prebiotics, probiotics is what I'm going to talk about. And lactin inhibitors. This is one of the newest things. I put this one in especially for my attending. It's one of the newest things being studied right now. It's actually in phase 2 trials. So therapy, I'll talk about the probiotics first. You can do the live. They're microorganisms. When consumed in adequate quantities, confer a health benefit to the host. The main probiotics on the market, lacto, streptococci, and bifidobacteria. There's prebiotics which stimulate growth and activity of beneficial bacteria, particularly the lacto and bifido. So probiotics, mechanisms by which probiotics affect gut flora and liver health. Inhibition of intestinal bacteria enzymes. So what happens is you have these good bacteria starting to compete with the bad bacteria in your gut, and you get your intestinal bacteria borders don't get disrupted now because they can't damage your tight junctions and desmosomes. You have stimulation of your host immunity and competition for limited nutrition. It inhibits bacterial mucosa adherence and epithelial invasion. So you have protection of your intestinal permeability, so you do not get translocation. New therapies. I pulled 2 or 3 studies on this actually recently, the galactin-3 protein. It's a family of proteins that bind to terminal galactose residues in glycoproteins. It's implicated in the pathogenesis of not just liver fibrosis, but other organ fibrogenesis. Inhibitors have been shown to reverse fibrosis and cirrhosis in rats, and now they're doing some human studies too. What they did find out, though, if you would take it oral, subcutaneous, or IV, which was most beneficial, and what they found out was IV administration once weekly decreases their NAS score and prevented accumulation of collagen. And some of the other studies that they're talking about, too, is that the reason this is working is because galactin-3 proteins are found on your hepatocytes and Kupffer cells in your liver. And so you have increase, actually, of this galactin-3 protein. And the inhibitors actually inhibit binding and fibrogenesis laying down by the hepatocytes and stellate cells in your liver. So this is why this works. So summary, after reviewing research articles on probiotics and on animals and human studies, it reveals an affirmatory effect of the probiotic supplementation on markers of non-alcoholic fatty liver disease. And there's actually even more ongoing studies on this. So it's a very promising field also. But now, with the galactin inhibitors that are coming out and it's emerging new treatment, I think after reading the research that I just did, that this is really going to help a lot of people out. Because not only does it reverse NASH and fibrosis, but it stops the laying down. So this is actually a treatment. We finally have a treatment we can do, not just something that can decrease and stop and progression, all this stuff, but actually a treatment for our NASH patients. So it's kind of a work in progress. There's lots of ongoing studies. There's lots of ongoing studies with gut flora and the microbiome. A lot of people are doing, there's so many things. We use VSL a lot in our IBD patients. We use it in our IBS patients. We use it in our fatty liver patients. And so I have a story where I gave every medicine to this lady with IBS, and still she just kept having abdominal pain, abdominal pain, abdominal pain. I was like, what is the world? I don't know what else to do. And so it was before I was even in GI, and I had gotten samples of VSL and gave her probiotics, and literally within 2 weeks she came back and saw me and said, oh, I feel much better. I'm all good. And I was like, and that's, I've always been interested in GI, and so I really like that. And I've always been interested actually in liver disease also. So this was kind of a win-win for me because I like to read and research this. But just so you guys know, don't forget how to work up non-alcoholic fatty liver disease. Thank you. Here's my references. I have a ton. Yes, Dr. Jane.
Sarah was used to explain about probiotics. There's great confusion about probiotics.
Okay, so
Live and dead probiotics.
So live is the best. And you know the difference is because they're going to tell you it's refrigerated. That's the biggest thing. A lot of patients are going to come to you and say they're on probiotics. And where did you get them? Well, I got them over the counter in a bottle. Well, those aren't the best because those are dead. Those aren't live bacteria. And you also have to be careful about that because if you just give it to just anybody with active infection like C. diff, or they're having active flare in IBD and they're having bloody stools and loose stools, you actually can cause a bacterial translocation because they're live and they can get endotoxemia. So you have to be careful about who you give those medications to.
Refrigerated. It has 2 bacteria. BDSL number 3, which is refrigerated, you can get at a lot of pharmacies, and it has to be refrigerated. It has 8 different probiotic agents that's effective. So when you prescribe that, recommend that, tell them it has to be refrigerated.
Thank you, guys. Oh, yes. You mean gut cleanses? A lot of people I know a lot of people do that. There's no research that shows benefit to that because what you could be doing is killing your good bacteria with the bad bacteria because it is non-selective. I hear that a lot. A lot of people go, I did a gut cleanse or whatever cleanse, and sometimes I think that's just a ploy on people to get them to buy their product. I think if you eat healthy and you drink a lot of water and don't put a lot of bad bacteria in your mouth per se by environmental triggers, that I don't think you need a cleanse. I think the cleanse would be water and just healthy eating, I feel like. I feel those cleanses don't do you benefit because it's not, if you could select out all the bad stuff, sure, but that can't. And so I don't think it's that beneficial, to be honest. There's no studies on it, really.
Was there another therapy out there besides what you went over for fatty liver disease? A lot of hepatologists are looking at this now in their patients that do not get better with standard weight loss mechanisms.
Bariatric surgery.
That's right.
Yes,
So,
they do talk about that. You can do bariatric surgery, but you need to pick your patients very carefully. You need to make sure that they're going to stick with it. I think a lot of people have had bariatric surgery that didn't know. A lot of them don't even know they're supposed to have their vitamins tested. You're not going to be able to absorb vitamins. You're going to be iron deficient. There's lots of things out there like your B12. And they weren't, a lot of them are like, oh, I was never told. So you have to be careful when you talk about bariatric surgery, too. They need to understand what's going to happen when they have bariatric surgery. But yes, if they talk about if all other therapies fail and you have a patient that's not getting better and you feel like they'd do, of course, much better if they lose weight, then yes, definitely bariatric surgery is a good option. I know they talk about also, Dr. James talks a lot about, used to do a procedure where we could put a balloon down to the stomach, fill it up, and make people feel fuller without having to eat so much food, without having an invasive bariatric surgery. So there's the sleeve, there's lots of options for that.
and is it only in obese patients that you see this disease?
No, you can have non-obese patients with non-alcoholic fatty liver disease. That's why you have to be careful and rule out other primary and secondary causes.
In fact, a recent abstract came out and showed that mortality was twice as high in patients who were thin with fatty liver disease than those who were obese, which is not what we would think should be the case. So
That's correct.
I think it explains that we really don't understand the
Right.
entire etiology of this process.
Well, that's why they talk, every journal I read talk about what they think, but at the end they always say that it's elucidated, meaning that they're not really sure. There's lots of things that they tie together that can cause fatty liver disease, but in the end, no one knows for sure which one is right, which one is wrong. I think there's lots of reasons, to be honest.
And I think something that might point to flora as being an etiology is weight loss. So do you get weight loss from changing your diet, or do you get weight loss from activity? So if you had two arms where all they did was change their diet, and then you had an arm that looked at activity weight loss, did they both have improvements in their scores and those types of things? And I
That'd be a
would
good
bet
study.
that you would see more improvement in those who change their diet, because I'm a believer that it's the flora that plays a huge role in this process. So
I think so, too.
that's just my opinion.
It's definitely true. Question?
You mentioned the bad bacteria or whatever, but where does that come from?
So they talk about that. So we have good and bad bacteria, but we're at a good stasis, meaning like it's at a good balance. But when we have an overgrowth of our bad bacteria versus our good bacteria, that's when you have problems, just like when you have C. diff. So it's like when you take antibiotics and you kill all your good bacteria, then you have C. diff overgrowth. That's kind of the same scenario. So right now you're in a balance. When you have an overgrowth of the bad, then that gives you your damage of your intestinal lining. You can get bacterial translocation. That's when all that starts to occur. So that's why they say probiotics and things like that, because you can replace those good bacterial flora and cause a more of a steady state between the two. Sure. They do a lot about diet, environmental factors. No, it's all about, they talk about, we have a lot of hormones in our food now. We have a lot of, they don't know exactly. They think a lot of the time it is what we eat. A lot of the fat accumulation, like I said, high fat and non-absorbable polysaccharides that get broken down by the gut flora. So those things start coming into play as what you put in your mouth. And so we don't know exactly, I don't know how stuff is made and how the meat's taken care of, stuff like, you don't know. I know there's certain percentages, just because I used to work in the restaurant business, there's certain percent of bacteria, bad bacteria like salmonella, even the infectious things, that a percent of it is okay if they find it in the food. I know that just from working in that business. So just like there's a certain rat feces that's okay that they find in certain foods too. So we don't always eat clean food. It's sad and it's kind of gross, but that's the truth. I know, exactly. And that's why because I did work in the restaurant business a long time ago through college and had to go through those studies and have to pass certain tests. I didn't actually even let the cooks make my food. I actually made my own. But yeah, it's so when you see those bad scores on your restaurants, when you look them up and Google them, I don't eat there.
So the number one cause of liver transplantation in the United States now is fatty liver, MASH. Okay? So guess what state is number one in the country? We're finally number one. Oklahoma is the fattest state in
That
that
is,
state.
yeah. We have a lot of obesity and diabetes in Oklahoma. So, thank you guys. I appreciate your time.